Over to Dr. Chitra Ramamurthy, who also needs absolutely no introduction, the chairman of I Foundation, which is now spreading wings because of her son, who is doing such a brilliant job.
Why not us?
And she, all of you know, that did a fantastic job as the main person, chairman of the ARC, did so many shows on a regular basis, was unbelievable. Over to Chitra.
Thank you very much, Dr. Kumar, for this wonderful introduction and taking to this talk. And of course, the opportunity to be a part of this very esteemed course, which brings in huge numbers of people coming for it. So my due is to talk on managing a threatened nucleus drop. Now, that's a most calamitous condition which we do face in our cataract surgical theater. It could be an iatrogenic PCR which has got created by us, or it could be an eye which already has a pre-existing dehiscence as in a polar cataract, or a PC touch has occurred in a prior vitrectomy procedure. So the main key is how to avoid the drop nucleus from dropping further, and this can happen only if we keep our eyes open to pick up those telltale signs in the posterior capsule or a zonular rupture which is imminently going to happen. It's also important to see the status of the vitreous, whether the vitreous is disturbed or not, whether we need to intervene to do a vitrectomy first or not. So for early recognition, the signs are there will be a sudden deepening of the anterior chamber, irregularly too. There would be a sudden expansion of the pupil, which is called the pupillary snap sign. There suddenly you could see an appearance of a red reflex somewhere in the periphery. Suddenly a nucleus which was nicely rotating no longer rotates, or there could be a little extra displacement of the nucleus and tilting of the pole of the nucleus, and suddenly you might see the nucleus is in the anterior vitreous phase. So before I go on to show you the videos, what we need to do is decide whether we are going to do a phaco or an SICS, and that's based on the amount of nucleus which is remaining. If it's a small fragment, we could actually tamponade the vitreous and remove it with a phaco. But if the nucleus is large and dense and it is admixed with vitreous, or if it is a small pupil, or if there's a weak zonules, you would have to think a lot more. So let me run you through some videos. Here, this is a polar cataract. And I clearly know that I have to create just an adequately small rhexis, because this might become the platform for placing the lens if the PC gives way. As of now, there is no clarity about how intact the PC is. And I go on to tent up the nucleus and do a lens capsule and do a gentle hydrodelineation. Maybe I was a little too vigorous. Keep watching. The nucleus suddenly comes forward, and look at the pupillary margin. That's pupillary snap sign. So I know I have a blowout of the posterior capsule somewhere, and the full nucleus is there, and I'm just not going to take any chance at the moment, and I decide to convert to an SICS wound, ensure that my inner opening is adequate because the entire nucleus is there, make a small nick on the rhexis because it was a smaller rhexis, just enlarge it adequately so that I'm able to topple the lens onto the anterior chamber and get it out smoothly at one go. I would have to suture my main port incision and then do a vitrectomy, ensuring that my IA is directed towards the corneal endothelium, not hydrating the vitreous, and then I place my 3-piece lens, but here I can't do an optic capture because I have already enlarged the rhexis. Now this is my second case. Again, a polar cataract, the rhexis is adequate, but I look at me, I'm doing a sideways sculpting because you can't rotate this nucleus. So this is one other way, but again I see a very clear red space, an unusual thing, and I know there's a dehiscence there, but I already have 4 pieces of nucleus which I have sculpted, and I get these pieces up. Probably this could have been done with an IOL scaffold, but in this particular case, again, I wanted to bail myself out even more easily. And as the pieces were smaller, I just make a small temporal sclerocorneal tunnel, and then making my inner lip a little larger than the outer lip, I just get out all the pieces, and it's just coating the endothelium and keeping the anterior chamber deep enough. It is done in absolutely no time. That last piece is also out. Then I do an anterior vitrectomy. And once I've done a vitrectomy, I can see the ease with which I'm able to strip the cortex is a clear indicator that the vitrectomy has been adequately done. Of course, a tricort was injected and to see if there was any vitreous strands, but this was fine. There was a nice round rhexis. So the 3-piece IOL was placed in the sulcus, and you can see I've nudged at the edge to see there's an optic capture. Now in this particular case, half of the nucleus was out and the half the heminucleus was there. There's a sudden shallowing of the anterior chamber. And again, I see that the nucleus is dipping into the vitreous, and at that moment, I go into the 2 side ports, and with the Simcoe's hook, I get the nucleus up into the anterior chamber. It was initially a 2.2 millimeter incision, so I enlarged the incision, and the plan of action here is to place my IOL scaffold. Now here, the vitreous disturbance is not adequate, so I'm able to visualize the area of the sulcus, and I'm positioning the haptic onto the sulcus right away at one go, and then I deepen the anterior chamber and enough coating of the corneal endothelium with viscoelastic, and very gently, carefully, repeatedly injecting viscoelastic, I get the errant nucleus out, and then I do a vitrectomy behind the IOL, and of course I see there's vitreous in front, and then do a vitrectomy in front. I would inject tricort, diluted tricort. This could have been even diluted more, 1:10 dilution, and then do a complete vitrectomy, and I get myself out of this case. Now this was another case where everything looked apparent at the slit lamp, and it was a dense cataract, and I've created a large enough rhexis, not too large. I follow all the dictums of the rule, a gentle hydro and decompression, and ensuring I rotate it so there's no stress on the zonules. But you know, I'm somehow not comfortable. First of all, my trenches were not deep enough, and I could do a sub-chop, but I feel that the lens is tilting. I'm just wondering, and then I decide, no, this is absolutely, the PC is open somewhere, I've gone wrong. So now I'm not able to visualize much. So I just lift up the nucleus, do just a gentle vitrectomy in that area of wound to get space to place my 3-piece IOL. Now initially the haptic was out in the wound, one of the haptic, trailing haptic, but then I ensure both the haptics are sitting on the iris and not on the sulcus, because I can't visualize much, and then eat up the nucleus, inject tricort, do a vitrectomy, and position the haptic into the sulcus, and then complete the case. I would never chase a nucleus once I know it's gone into the anterior vitreous phase, because the amount of traction on the retina is extremely hazardous. Now this is again another polar cataract. Now I do my hydrodelineation, and I sort of debulk the epinucleus, but suddenly I slow down, like it was going at a fast rate. I normally don't operate that fast. But then I realized that some sinking thing is happening, so I immediately realized that the PCR has opened up, and I was lucky in this particular case that the epinucleus and the thing came out very easily, so I start doing removing it, and then do an anterior vitrectomy and removing the cortex. Then I see that small fragment of nucleus coming forward from the deep in the capsular fornis, but even before I realize it, it has gone into the vitreous. But I continue to do a complete vitrectomy, anterior vitrectomy, and then I tease out the cortex, and the ease with which I remove the cortex tells me that the vitrectomy is adequate. I polish the anterior capsule, and I make a suture in the main port. I do not hydrate the side ports. I take it to get the retina surgeon, remove it, then bring it back, and then here, there is adequate posterior capsule superiorly, inferiorly. So I inject my premium IOL, multifocal IOL, into the capsular bag. There's a central rip of the PC. So once I position the haptic in the capsular bag, I just nudge the optic so that I get it up onto the rhexis, which is what you call as a reverse optic capture, and then secure the wound. Now, supposing it's a case of a PC, like you can see here, AIOS2025 is telling me that the PC is not to be relied on. So I again stain the anterior lens capsule. I make an adequate size rectus. These are, and here actually I see that this cataract is quite soft. I reduce the bottle height, and here I don't have to do much. I just aspirate with the IA itself. So I know there's an area of lens touch. There is an area with the PC, but you can clearly see it was just a small rent, and I placed the 3-piece IOL in the sulcus and got away. This was again another case of PC touch, and the arrow is telling you that's where the PC touch was. So, but then I know I have to go ahead and get the nucleus out. So I'm very ensure that I do a proper size rhexis, a complete rhexis, a hydrodelineation, and endonucleus is prolapsed out. Then I do a viscodissection, and I get the epinucleus out. These are the ways at which I would do it all the time, keeping my anterior chamber stable. and then I noticed that area of lens touch. So, but yet the vitreous has not disturbed. So I go about doing the cortical wash and I place my 3-piece IOL on the sulcus, but there was a little forceful injection and that area of PC touch opens up and all the silicone oil comes forward. I try to remove some of it, but I suture the wound, do an optic capture and send it to the retina theater for the evacuation of the silicone oil. This again a case where there is evidence of lens touch, as was told by the surgeon, post-intravitreal injection. So herein, it's an intumescent cataract at that. So this rhexis is so important. So I use the onion peel technique, slowly enlarge the rhexis because I know anytime this rhexis could run away, and I just managed to get that adequate size rhexis I need to deal with this moderately dense cataract. And the same techniques of hydrodelineation because it's could be an open capsule. But what I find is when I'm gently making a little broad trench in the center before I start my job, I find that the part of the endonucleus is coming up, like small flocculent fragments is coming up. So whatever comes up, I get it. So that essentially I'm debulking the central core. So that gives me the advantage of doing a viscodissection. But yes, the ease with which this far things are going, I know it's an open capsule at some part, but the fact that the viscodissection is bringing up the epinucleus are indicators that the vitreous is not yet disturbed. So I keep doing a very gentle epinucleus removal. But here I feel there's a small clear reflex in that part, the inferior part, but still there's no vitreous disturbance. And I do a very slow aspiration of the cortex. And again, the ease with which the cortex is coming is still an indicator that the vitreous is still not disturbed and still the vitreous face is intact. So then I inject viscoelastic. I notice that there's a PCR there. By the time the PCR has become a little bigger, I position the IOL onto the sulcus, then inject tricort, do an anterior vitrectomy behind the IOL, and then finally do again an optic capture, which ensures that the IOL remains centered and you don't have to change the power of the IOL if the IOL is centered. Thank you very much. These were just different ways which I tried to show you all to understand that even if there's a PC blowout, how you could manage your surgery, be it an IOL scaffold or an SICS or a gentle phacoemulsification. Thank you. Volume. Mic is not on.
Hello. Fantastic, Chitra. Professor Valdemir or Dr. Rohit Om Prakash, would you like to say anything?
I think with an open PC, the fluidics are the most important thing, and so is the chamber stability. By fluidics, what has been Vasavada et al. Have taught that with high fluidics, even an intact anterior hyaloid face can be broken. So one needs to work at a lower IOP, physiological, as Dr. Ramamurthy works at 30. I think that's the perfect thing which has to be taken into consideration. So, and you should never let because posterior capsule rupture is one thing and anterior hyaloid face getting broken is the second thing. So in our mindset, we have to differentiate between the two things. We have to create a situation wherein we can have an anterior posterior capsule rupture and still not have an anterior hyaloid phase rupture. And if we do not have an anterior hyaloid phase rupture, if we use low fluidics to our advantage, we can make the faux an ally. Faux means the anterior hyaloid phase or the posterior capsule, anterior hyaloid phase for that matter, as an ally. Yeah.
Please.
Yes, wonderful cases. Thank you. I would just like to emphasize that when we have small pieces of a cortex, then we can use dry irrigation aspiration, or we can irrigate with the viscoelastic, with methyl cellulose, and aspirate at the same time bimanually. And this is very safe, not induce the hydration of the vitreous and preventing vitreous coming in front.
Thank you. Thank you very much, Kumar.
Any questions anybody would like to ask Professor Chitra? So I think there were fantastic cases, Chitra, at every stage, how to manage if there's a complication, because everybody is going to face it. For your information of the audience, that IOL scaffold was also an invention by Dr. Amar Agarwal. So we are now, all of us is implementing it, and it actually helps you to hold on to the nucleus in the front of the, well, preventing it from falling behind. Am I right?
Yeah.
So thank you very much.